back for another 75 minutes of presentations and discussions. So after we talked about mechanistic research and observational research, we now have two presenters talking about intervention research in immunopsychiatry. What is the state of the art and what are future goals? This will be a combined talk by Bernhard Baune, who is a professor in Münster in Germany, together with Carmine Pariante, who's professor at KCL in London. And they will be talking about the intervention research evidence in the field. And I think since I see Bernhard start slides, he will be the first person talking. Bernhard, welcome, and the floor is yours.
That's right. So I hope you can see my screen. So thanks very much, Brenda, for the invitation to talk today. And as you mentioned, we will do that together with Carmine and myself. So what we try to do today is to address, some of the points Brenda has given us to think about prior to the presentation. And these are, she just mentioned, what to learn from the link between immune system and psychiatric conditions from a clinical and clinical trial perspective. We just had the discussion in the previous talk, and I think one important point needs to be added. So which are the biomarkers, for example, which are suitable for clinical trials and then in subsequent clinical practice? For example, measuring T cells in clinical practice might not be possible perhaps in 10 years' time, but not now. So I think there needs to be some applicability of the findings, and that we will also talk about today. And then we will talk also about what do we not know yet, and these are related to the fact that we have missing knowledge on what target to choose, what agent to choose from, and we'll talk about that in a moment. There are different agents in clinical trials, and how is actually the agent and biological measure relationship. There are a number of methodological issues we will talk about today in RCTs, and this is on sort of biomarker type RCTs. We'll discuss that, and how to clinically stratify then the different patient population. And that was also a discussion point from the previous two presentations on who are the patients basically suitable for a clinical trial. And then, of course, there are a number of limited knowledge on mechanisms. And we heard that in the first presentation. We have some mechanisms, but we cannot pinpoint them very specifically to target them yet with agents. So that's another challenge. However, despite all these challenges, we also want then to, at the end, discuss of how we want to or could advance knowledge in the field, particularly on suitable patient selection and stratification for immune RCTs in the future, and what are the opportunities then for the ECMP network. So in a recent quite nice review by Drevets and colleagues in Nature Review Drug Discovery, they set out criteria for what they call immune targeted precision medicine in MDD. And I think this may also apply then to bipolar disorder, schizophrenia, or other diseases. And these are the 4 criteria they mentioned here. The first one is on causality. So before treating someone with a drug that targets a mechanism, there needs to be a causality between the immune dysfunction and depression in this case. And that is not so easy to establish, as we have learned in the previous talks, but there are some promising targets there on potential causality. Then targetability is another important part, so that the target can also be reached basically either directly or upstream or downstream within the molecular pathway, so that the drug can actually deliver its actions at the target. So that is a very challenging part, but I guess and Brenda mentioned that in her presentation, that a sort of more multi-omics type approach might be suitable to look at a systems approach on pathways and then changing the functions of these pathways through certain targets. So I think there will be new knowledge coming out there as well. And then diagnosability. So the diagnosability is basically what we call patient selection based on a biological marker of how can we do this from a scientific perspective, and then of course for a trial also in a sort of clinical practice perspective as well. And then of course unmet needs. I think there is no question that we have a large unmet need in immune psychiatry for treatments. And I think that there's certainly a big area there, for not just for MDD, but potentially also cross-diagnostic in other areas. Now, in the last sort of 10 years, there have been a number of different meta-analyses being performed. It started first with a meta-analysis on cytokines and how they are upregulated in depression. And then subsequently, various meta-analysis looked at certain interventions in MDD in particular. And you can see here a collection of 3 different meta-analyses from, four, 3 on the left, Köhler, Kappelmann, and Köhler-Forsberg, which look at mainly sort of anti-inflammatory on NSAIDs, or non-steroidal anti-inflammatory drugs, cytokine inhibitors. We heard about cytokines before, TNF, so TNF-specific targets, so blockade the TNF receptor and TNF activity, and then glucocorticoids, statins, minocycline, and also pioglitazone, which is an anti-diabetic medication. And these are sort of overall meta-analytic results, and they seem to speak to the effect that sort of NSAIDs might have a role in treating depression and improving depressive symptoms in different meta-analyses, but also cytokine inhibitors, as well as glucocorticoids and statins and minocycline. And on the right-hand side, you see the Wittenberg, the most recent meta-analysis here, which looked at sort of 10,000 participants in 18 RCTs of immune modulatory drugs. And you see here then different types of drugs. So modulating TNF, IL-6, IL-12, or the P38 MAP kinase, a CD20, so a T-cell marker, and also COX-2. So what is, and here is, you can see a sort of a mixed result. On IL-6 and IL-12/23, there are statistically significant results, whereas the other markers didn't show significant effects in improving patient groups. What is important to note, however, these are overall meta-analytic results. So I don't have the time to go into the individual studies, but you would see in the individual studies that many trials in the past have been negative, even in the NSAID area. So sometimes the overall positive meta-analytic effect is driven by 1, 2, or 3 studies which have a large effect, and let's say 8, 9 studies have no effect, but still the overall meta-analytic effect is then positive. So that can be sometime challenging to interpret and then come out with sort of overall recommendations like these. But anyway, this is the evidence we have so far. And this is then, I don't want to go into the details of that, but I would like you to have a look at the Drevitz and colleagues paper, because here they look at the individual targets, so the different drugs like infliximab, for example, with blocking TNF in MDD and bipolar disorder, and IL-6, for example, as an adjunctive treatment to monoaminergic antidepressants, or the P38 MAP kinase, and minocycline given adjunctively. And later on, we will also hear from Carmine Pariante talking about a minocycline trial. Well, what you can see in these individual studies, that several are not significant in reaching a difference between treatment groups. So that is important to note, that there are different reasons for that, small studies, that's always a challenge in clinical trials, and others as well. But this is not uncommon. And similarly, also for COX, celecoxib inhibitors, for example, there are some effects, some positive, some negative effects. But the point why I show this slide is when you look at patient stratification, which is sort of right here in the middle, you see that none of these trials have used patient stratification. So, for example, stratification into those groups with a higher or an inflamed type status, or let's say certain biomarkers, could be stratification, or it could be a gender stratification or symptom stratification. So these stratification trials have not been done yet. And I think that's a great manko in the field. But on the other hand, introducing stratification is a challenge, because you need then much larger numbers per group, and you need to kind of homogenize the group prior to the trial for stratification purposes. So here we see sort of some advances, but also challenges. And I think the next part, Carmine will jump in before we then move on. Carmine, it's yours.
Thanks.
Carmine, do you hear?
Thanks,
yeah.
Yeah.
Oh, great.
Thanks, Bernhard.
I'm happy to move the slides forward once you let me know.
Thank you. Thanks. So for the first few slides, I just want to kind of discuss a little bit more the conversation we have had so far about does an inflammation or inflammatory depression exist as a separate, distinct entity versus, are we looking at a biological abnormality that is relevant across all depressed patients? And because the bottom line is that if you look at treatment data, as we kind of, at least some indication from treatment data, as we have discussed before, and as we can discuss more in this talk, there is some evidence that there is a stratification that will help identify patients who respond. However, if you look at the biological data or the epidemiological data, as Brenda and as discussed, and Michael has just discussed before, this evidence is not there. So I'm just going to kind of briefly go through this notion and give you a couple of kind of evidence from our study supporting actually both ways. So this is the paper in the slide now is the first paper that we published from the BioDepth study, which is the largest study kind of ever conducted in a clinical population. So patients that were all kind of seeking help from a clinical point of view without diagnosis of major depression, some of them treatment resistant, and some of them they were depressed but not on antidepressant. And if I can have the next one. And if you click again, it will show, yeah, perfect. So, oh, sorry, one more, yeah, just here. So as you can see, just a simple,
just on this one?
This one, thank you.
Okay.
And as you can see, even just by comparing kind of healthy volunteers, depressed patients who are responsive, so if you like, are more in a trait, we're more identifying a trait situation because they're depressed, but they're currently well, and or treatment-resistant major depression. So people that are currently depressed, they are on antidepressant, yet they're still suffering from depression. Well, you can see the very bottom line is that we can identify as more proportion the numbers that Brenda has presented before, also from us, very similar to previous meta-analysis, of around 20, 22, 23% of kind of depressed patient in general, if you like, in this case, the responsive, and a bigger proportion, around the third, 29% in this case, of treatment-resistant major depression, that have a CRP above the threshold of 3 milligrams per liters, which is the one we all use because really we've imported that from kind of cardiovascular disorders and the cardiovascular and the diabetes literature, not that it was never kind of a psychiatric decision to use this as a threshold. So obviously the line just above it, you can see that the average of CRP is of course higher in treatment-resistant depression compared to treatment-responsive, and in treatment-responsive compared to healthy volunteers. So basically, this is a slide that shows some kind of separate group of depressed patients that have high level of inflammation as defined by CRP above 3. However, if we look at the next slide, this is a paper that, again, Brenda's mentioned, that we published on the UK Biobank, so a much, much larger sample of around 27,000 depressed participants, which of course encapsulate a broad range of clinical severity, but mostly on the mild to moderate side. And in fact, a lot of the people captured as depression here were lifetime depression, where the blood was taken either before or after the diagnosis was made. And so, if you like, we were helped by the huge sample, but we were also going against all the odds of finding an abnormality, basically, because both the depression severity was low and the association between the blood measurement and presence of depressive symptoms was really kind of unpredictable and going both directions. However, even in kind of using all these caveats, if I can have the next one. And the next one again, just the next panel, and one more, there is another paragraph. Thank you. So if you actually look at the data, what you can see is what we define as a shift to the right of the value of CRP. So the figures on the left shows that for moving across CRP ranges, so the kind of 0 to 1 milligram per liter on the left, which is what we basically we will consider absence of inflammation. Then, of course, more controls, or more people who have never been depressed have CRP in that range, and fewer depressed person. Once you move into 1 to 3, there's almost like a balancing of proportion. And then above 3, more depressed patients than controls have higher inflammation, kind of belong to the category. But you can see it's almost like the depressed patient have a shift to the right of the CRP level values, so that it is almost like across all values of CRP, there is a movement, there's a worsening or a slight increase, and not only at the kind of highest level. So this, if you like, would object that the inflammation is relevant across all of depressed patients, and across all spectrum of inflammation. There is an element that depression provides of increasing inflammation. Again, if you look at the numbers, we found CRP level above 3 in 21%. Very similar to meta-analysis data, very similar to the 22% we found in treatment-responsive depressed patients. So in the population, as we said, they probably show a trait effect rather than a state effect. And perhaps not surprisingly, we also found that the highest CRP was associated with age, sex, BMI, smoking, everything that you would expect, trauma, low socioeconomic status, and worse ill health. However, again, if I can have the next slide. And if you click 2 more times, so the 2 highlights appears. Perfect. So I just want you, without spending too much time, I just want you to look at the bottom, the top left highlight numbers, and then we're going to look at the bottom right in a second. So the top left is the association, is basically the least adjusted association between depression and CRP. So it shows basically that there is a positive association. So being depressed increase your level of CRP. The model 1 is actually just adjusted for age and sex. And then as you move right, you adjust for age, sex, smoking, and BMI. And as you move down, you adjust for trauma. So the presence of childhood trauma. Then you adjust for trauma and socioeconomic scores, or obviously for lower socioeconomic scores, and then for ill health status. You do all these adjustments, you move toward the kind of bottom right, and you still find, of course, a smaller but yet significant association between CRP and depression. So there is something about being depressed that drives CRP, which is independent of anything else that you can consider, including a lot of the factors we've discussed today, metabolic factor, BMI, health style, smoking in this case, kind of events happening around our life. And so there's something about the diagnosis that drives that CRP. And so, how are we can we tackle this particular element of inflammation in all depressed patients? And or is that a theoretical approach that actually doesn't work once you test into practice. And I'll ask Bernhard to continue from here to try to address this question.
Yes. No, thanks very much. And what I would like to introduce then is a study where we again looked at CRP. So here this is a PREDICT study, it's called, and the idea of the PREDICT study was to consider prior to the trial the CRP levels in patients with treatment-resistant depression. And so here you can see the basic idea, and I think it takes into consideration the stratification point, the point Carmine just made on that there is an inflammation measurable in these patient groups, but not everybody has it. So there's just a proportion of patients even within the treatment-resistant group. So this is why we designed this study, and this is the methodology paper 2018. So it's a few years back now, and the study has been completed. And I will show you the results in a moment. But this is the design here on the bottom. So CRP levels with a cutoff of 3 milligrams per liters. And then patients were stratified in both groups, above and below the cutoff, and received in a placebo-controlled RCT, then vortioxetine, which is an antidepressant, plus celecoxib, so an NSAID, versus vortioxetine plus placebo. And so basically the RCT was then done in 4 arms, if you like, based on the biomarker stratification prior to the trial, which lasts for 6 weeks of treatment with celecoxib versus placebo. And then we had a sort of a 2-week observational period. So they continued on vortioxetine, but without celecoxib then. So there was end of RCT week 8, and then we had a post-RCT observational period of week 9, 22, and 35. So where they continued on the vortioxetine only. So here the primary outcome here was to look at change in symptom severity using the MADRS, or the Montgomery-Åsberg Depression Rating Scale. And then we had a number of secondary outcomes. So like from quality of life, suicidality, emotional blunting, global functioning, workplace functioning, and also cognitive functioning, because we know that in depression, cognition is very poor in a subgroup of patients. And one of the secondary questions was whether the anti-inflammatory treatment would change any of that cognitive dysfunction. And we had a number of biological outcomes, so protein markers of inflammation, and you can see some of the cytokines, as well as transcriptome-wide changes we are investigating at the moment, and also genetic changes, as well as other cytokines and inflammatory markers, neuroplastic markers, and so forth, which are in current analysis. Now here again, you see the trial, which has now been, so on the primary outcome, which has been published just this last year. So from screening, there's baseline, the celecoxib placebo treatment with vortioxetine for 6 weeks. And this is what we are looking at now as the main result. So here the main result is on the left-hand side of the PREDICT trial. So looking at the overall symptom change of depression. And what you can see here, basically, that both groups did improve over time. And in other words, vortioxetine did its job in improving symptoms, and the score went up from around 27 on average at baseline, so which is kind of moderate to partly severe depression, to around sort of 19 at week 6. And the second important message is whether there was a differentiation between celecoxib and placebo-treated patients, and there was not. So you see a numerical difference between the 2 lines, but there was no statistically significant difference between the 2 lines. So that answered an important question here. And the secondary outcomes, like the cognition, which is measured on the right-hand side with the DSST, so the digit symbol substitution test, shows that patients improve in cognition over the 6-week treatment, but they did not differentiate between celecoxib-treated patients and placebo-treated patients at all. And similarly, for the functional outcomes, which is measured with the FAST, or the Functional Assessment Short Test, here you can also see a change, so an improvement from baseline to week 2 and week 6, but no major or significantly statistically significant difference between the two treatment arms. So that is an important measure. And what I'm not showing here is, but I can show on the next slide, that the level of C-reactive protein at baseline, so whether someone was higher 3 or below 3, or so at a categorical level, or even at the continuous level, C-reactive protein did not predict treatment response to celecoxib. And in fact, I just had got it back the other week from our lab, the results on change in CRP, so high levels of CRP did not change during the trial. So the pre-treatment level of CRP, the baseline level of CRP, and week 6 level of CRP did not change in either group. So neither in the entire cohort, nor in the celecoxib group, and neither in the placebo group. So the anti-inflammatory did not change the C-reactive protein level. And now we're investigating how much then other markers, including cytokines, including neuroplastic markers, including T cells and so forth, would change between the two treatment groups. But so far, we don't see that at all in this particular trial. And it was a fairly large, relatively large trial with 112 patients. So it's probably not large enough for the subgrouping and the certification, but it was still a relatively large trial in comparison to others. So overall, it was a negative trial in terms of the primary research question, but we also addressed some other questions like the CRP change, which we could not detect in this trial. Why this is the case, we don't know yet. Carmine.
Okay, so literally around the same time and in the same journal that Bernhard was publishing his trial, we published our trial on minocycline in depressed patient. And actually the lead author is Valeria Mondelli, who is on the call, and I will ask her to comment on the study in a second, but I'll just go to the slide first. If you just click one more time to highlight, perfect. So it's not a stratification study per se, but we recruited only patients with CRP above 1 milligram per ml. So we enrich, if you like, for at least mild level of inflammation, and we were with, of course, the idea that those would at least increase the chances of finding an effect. Although we did stratify post-doc, as you'll see here in a second. The next one. Okay, so this is a big slide. It's a kind of busy slide, and you don't need to look at all the numbers. I think if you kind of look at toward the bottom of half, you will see the stressful life events and the baseline CTQ total scores. I mean, this basically was a population with a with a remarkable presence of both historical and current life events. Of course, they all fulfill the criteria of major depression. And as you can see, sorry, I forgot to say the most important thing, is a randomization of minocycline versus placebo, add on whatever antidepressant they were on it. Of course, and they were not responding to it. You can see the bottom two lines are the basal Hamilton. It's like, you would expect that this two randomization is very similar, 19 and 17. By chance, the CRP tend to be slightly higher in the placebo group. The average was 3 in minocycline, 4.4, 4.5 in the placebo. Since we've recruited everybody above 1, the average value tend to be higher than in the general population of depressed patient. The next one. Okay, so if It was a negative study, in exactly as Bernhard kind of also presented for his. In terms that when we looked at all the samples together, there was an improvement of depressive symptoms across both minocycline and placebo, but there was no significant difference between study arms in the change of the Hamilton. So we didn't find an effect in the whole population. Now, we also looked at a more kind of treatment response based way of measuring response, and we identified the number of people who show at least a partial response, so 25 reduction in the baseline scores of the Hamilton. We couldn't, I think there was only one that actually showed a 50% response reduction, so we couldn't really use that definition. But even by using this definition of 25%, again, the numbers, all partial responders were very similar, 44% in the minocycline group, 43% in the placebo. Next one. So that's when we decided to do a further stratification. And so we decided to, we stratified the sample for CRP above and below 3. And these slides represent the key findings of the paper, if you like, and the key positive findings of the paper. So these are the delta change, or the difference between the Hamilton at the baseline and at the follow-up. And it's a 4-week trial. Sorry, I haven't mentioned this before. It's a 4-week trial. And you can see that the only group that really shows an effect is the group on the left. And this is the group with CRP above 3 that received minocycline. And if you move from left to right, the group of CRP above 3, which was on placebo, didn't really show a big improvement. The group that were below 3 and was on minocycline also did not improve. And of course, at the right, the group that was below 3 and was on placebo didn't show any improvement. So in this case, the stratification did work in showing that you need to have a threshold CRP above 3. We actually did even a ROC analysis to kind of look at the data hypothesis 3, and the ROC analysis showed that 3 was the right point to separate responders from non-responders. So it kind of, we got it both by hypothesis-driven and hypothesis-free analysis of the data. And the next slide. But even here, like in Bernhard, no change in CRP. So you can see the CRP value at baseline at week 4. The first line is both samples together, basically. So the whole sample are the following minocycline or for placebo, and there's no difference with minocycline. If you can see 3.3 versus 3.3, 3.13 versus 3.3. No difference with placebo either. And even when we look at the post-hoc stratification, so the highest group was 5.6 or 5.7 and 6.6, which are the two groups that were selected as CRP above 3, there's really no change, either with minocycline or with placebo. We saw a signal with interferon gamma, that it does decrease with the minocycline. So perhaps CRP is helpful in stratifying patients, but it's not helpful to track response. But we're also aware, as you can see from the number, that those were small numbers. Valeria, is there anything else that you want to add or comment on the paper? I hope I've done a good job in summarizing it.
You've done great, Carmine. I think, yes, you pointed at the right results. I'm happy to kind of discuss. I have, of course, a lot of ideas of why we have these findings, and also coming back on Janet's point on the stratification and the transdiagnostic, I have also quite a lot of thoughts about that, but I maybe kind of stop and let you go forward with the presentation first. Yeah.
Okay, Bernhard, I'll pass it over to you.
I think one really important point is CRP is, we all know that CRP is a crude measure of inflammation, but I think the reason why we selected that, and I guess similar also for Carmine's trial here, is that it is clinically translatable. So all labs, clinical doctors' lab could determine a CRP level, and that might be translatable then for patient selection in clinical practice. So that is, I think, one of the reasons why it's been tested. And just before I go on to add to this, is there was also last year an NSAID trial in bipolar depression, published in Lancet Psychiatry, which also showed a negative result in terms of the add-on, the augmentation effect, if you like. So, but you know, this shows, I think, that it's not as simple as we thought, that there is a simple inflammation, and we target that with an anti-inflammatory, and we see like a clinical biology consistent change, you know, in symptoms and inflammatory markers, maybe some, but it's not that simplistic, I would say. But still, there is something we need to work on to have a better understanding. And that leads me to the next point on discussion, really, of how should we actually do clinical trials with biomarkers. And there are different ways of doing that. And I would like to show 3 different ways. So this is here a principal presentation of doing a stratification based on a biomarker. And that's what we've basically done, and Carmine has done the same with the CRP, looking at above and below 3 as a cutoff. So this is you assess your biomarker, and then based on the biomarker result, it's a positive, means above a certain threshold, or negative or not present at all. In our case, it was the cutoff of CRP. And then you randomize your treatment arms basically based on the biomarker. And then you have treatment A versus treatment B. So our trial, the PREDICT trial, was basically followed this biomarker stratified design. But that's not the only design. You can have other designs. And there's on the left, there's an enrichment design here. So basically you assess the biomarker and select only those patients who test positive for the biomarker. Let's say positive in terms of threshold, for example, only patients with a CRP level of 3 and above, or any other biomarker. As soon as the biomarker is negative, patients don't get studied. So it's an enrichment for a biomarker, and then you randomize your enriched patient group into treatment A and treatment B. And the third biomarker strategy design is here called the biomarker strategy design. And that is you randomize your assessment of the biomarker into a biomarker directed arm and a control arm. So biomarker directed arm means that you use the biomarker to distinguish between treatment A and treatment B. So those who test positive for the biomarker get treatment A, probably the target treatment here. And if they're biomarker negative, you test treatment B, so the alternative treatment. And you compare that basically to your control arm, which is not biomarker directed, with treatment B. So therefore you have a sort of a double negative control, so to speak, within the design. And as far as I know, most of the studies have not, in immunopsychiatry, have not used these different biomarker designs. I'm not proposing that we should use A, B, or C, but I think we should think about then different design issues within the trials, and which design would lead to which type of result. And that is, I think, a discussion we need to have, and that hasn't been sort of conducted so far in the literature or in the literature reviews or even in the meta-analysis. Methodological aspects have been sort of neglected so far, but I think this is an important part when we move forward for what we can do in future. And this is basically sort of the last slide, and please come in, jump in to add. But here kind of are those criteria where we think there are opportunities, sort of low-hanging fruits perhaps, for the network, what we could do. The first thing could be to pool existing trial cohorts for a meta-analysis where biomarkers have been used, you know, like we discussed that, or we conduct post-hoc biological analysis on existing biological data, and then we could pool those. Or we also look at these stratified trials, which are now sort of more and more conducted, only a few, but some have been conducted. And we look at the existing biospecimen and develop a more omics type approach, more systems biology approach for a post-hoc analysis of new biospecimen in these data. Or look also and discuss as a field more broadly of how we want to stratify our patient groups for clinical trials. And I think we need to have some discussion on that. And perhaps to close the circle here from the very beginning with the criteria published by Drevets and colleagues, perhaps we also need to expect in future immune trials to meet certain trial criteria on causality, targetability, diagnosability, which is basically patient selection, and unmet need. I think we cover that part for sure. So that's sort of the end of this presentation. Perhaps Carmine wants to add some points I've missed, perhaps.
No, I think you've covered it all really well. So I think it'd be good to open up for discussion.
Oh, okay, thanks very much.
Thank you.
Great, thank you very much for two very nice combined talks. And I know that there are quite a few things asked about in the chat. Some have been addressed already in the chat as well. And I know Livia is probably combining now several questions that were also raised in the chat in a more general discussion last part of 30 minutes. Livia, are you okay with now taking on the general discussion, and will you touch on the questions in the chat as well, or should I first ask a few general questions?
Well, I prepared an overview of, I think, the learning points or hot topics of this morning. So I have just 2 slides, and then I will open the general discussion in which I invite all the presenters of this morning to join us. Please turn on your camera and your microphone, and then let's have an interesting discussion. For the questions from the audience, they can either be put in the chat, and I will read them to the presenters, or you can join the discussion and ask the question yourself.
Okay, then I would like to give you the word and start with your overall impression on discussion points, and then we will get back to the questions in the chat. Yeah.
Okay. Well, first of all, it's an immense pleasure to be here with you this morning in the presence of a very large amount of participants or researchers with a vested interest in immunopsychiatry. And this is particularly striking considering that our field of study is actually relatively new. Of course, it did evolve from an earlier field of study called psychoneuroimmunology. And while both scientific fields are closely related to one another, I do think they are quite different in their focus. So psychoneuroimmunology traditionally has been a field of study looking at the fundamental interactions between the CNS and the immune system, whereas immunopsychiatry stresses more the clinical impact and wants to harness the immune system to improve the clinical outcomes of patients with mental health problems. So if you look just in PubMed, I did a search last year on the number of papers with a hit on psychoneuroimmunology on the top versus immunopsychiatry at the bottom. You can see that the latter term is not used so much, but I do see a clear increase in the last decade, and I'm sure we will see much more work coming out using that term. So I'm quite sure that just like me, if you're interested in immunopsychiatry, it's not just because it's very complicated and therefore very sexy and interesting field of study, but probably you're also hoping or believing that our work really has the potential to, if not revolutionize our clinical practice, at least bring a meaningful clinical innovation to a patient group with very high unmet clinical needs. And I guess the presentations of this morning really prove that even in a very short amount of time, we have learned so much, we've come so far. The evidence of immune effects in mental health problems is overwhelming. And the compounds that we need to address these problems are already on the market. So while we are so close, still we're not ready, or at least we feel we are not ready to start implementing this in clinical practice at a large scale. And earlier this year, I had the privilege to dedicate some time thinking about this question. What is needed to move this field forward if we would be designing a strategy from where we are today, and then thinking about what is needed to start implementing this in clinical practice, which would be the critical steps or milestones that we need to take. And I was quite happy to see many of my own thoughts being repeated today in our presentations and discussions. So 3 critical milestones towards clinical innovation. Firstly, we need to have a clear definition of who are the patients who will benefit from our immunopsychiatric approach.
Livia, we're still seeing your first slides. I think you probably want to show the second.
Yeah, let's see, we can just share it again. There we are. Is this better?
It's not presenter view.
Yeah, it is better, but it's indeed, I mean, I think it's readable, so I'm fine with it, but.
Probably you're using 2 monitors and you are sharing the wrong one. Probably you have to
this one? Okay, we're there.
Yeah.
Perfect. So I was presenting the first milestone, a clear definition of the patients who will benefit from our approach. And I guess this is about the patient group, or more likely groups of patients who we should be targeting. And we've heard a lot of suggestions already this morning. So we could potentially look at baseline immune markers, but then the question is which marker and which cutoff. CRP has been mentioned, IL-6 has been mentioned. Potentially other markers could be explored. Or we could look at the immunogenetic makeup. Potentially we need to look at people with a certain HLA polymorphism. Or maybe it's much easier to not go into all of the biology, but then just look at the depression subtype. So Brenda has mentioned that apparently the people who have disturbances in cytokines are more likely to also present with an atypical depression subtype, with also more metabolic symptoms. Or maybe we need to focus on patients with already existing comorbid autoimmune disorders, patients with rheumatoid arthritis or psoriasis or multiple sclerosis, etc. Or maybe it's easier to tackle the patients who already present with obesity or some other kind of metabolic dysfunction. Secondly, in those patient group or groups identified as the core patient group involved for immunopsychiatry, we then need to demonstrate a very well-defined clinical benefit, which can then be incorporated into clinical guidelines. And well, already many placebo-controlled RCTs have been conducted. So what more do we need on top of that? I guess this has already been mentioned also this morning. We need to select the right patients by stratifying for certain immunosubtypes. And I was very happy to see in Bernhard's presentation that there is more than one type of design that can be chosen to do so. But also we need to select the right treatments, because we have studies with celecoxib, with aspirin, with minocycline, IL-6 inhibitors, steroids. How do we know which drug to use in which patients? So actually we're going to need both stratified designs, but also multi-arm designs with different compounds, different doses, different treatment durations, which is obviously very expensive in a field of study where usually the pharmaceutical companies have not been so interested. So how are we going to do this? And then lastly, I think, and this has not been touched on so much, but we need also some convergence with other paradigms, already existing paradigms in biological psychiatry. How does this integrate with everything else that we already know about neurotransmitter dysfunctions, about neuroplasticity, about genetics, about the role of childhood adversity? It's our job, I think, to study these interactions and these links and propose an overarching model that will not present immunopsychiatry as a separate niche for a small subgroup of patients, but really in an integrated model for biological psychiatry. Because then we can also start teaching this in the regular psychiatric curriculum. It can be the regular textbooks. and it will really become part of mainstream psychiatry. So this was my questions and suggestions that I saw in terms of moving our field forward, but I very much welcome the opinions and the input of our presenters and from the audience. So I'm going to stop my screen share and allow the debates. So maybe I know Janet, but also Bernhard and Carmine, you've actively commented on the stratified designs and different ways to do RCTs. If you would be designing an RCT today, what would you do?
Well, perhaps I can. Well, I would try again the first design. So the one we used already in the PREDICT study. I would do that again. I think that's a good way of doing it. So like a biomarker, using a biomarker and a cutoff into two groups and then treat them the same way. That's one. Or the other one is to use then the second one is like an enrichment for a certain biomarker. And that biomarker, of course, doesn't need to be CRP. It could be also polygenic risk score, for example, if we find something like that. Although we heard today, that there's probably less of a genetic liability for inflammation in depression. There are lots of environmental factors, so that might be difficult to do with a genetic risk factor, but the enrichment design, I think, is an important one too. And when we talk about immunopsychiatry, then of course we also need to look at other types of interventions, not just pharmacological interventions, because there are numerous factors from food, from also diet in general, physical activity, from trauma, which drive also inflammatory pathways. So we could also think about enriching a trial based on these more sort of clinical and or sort of health behavior type factors as well. So, and therefore with an enrichment, you probably get a higher chance to identify the right patients and to get actually a signal out of your trial.
Well, for sure, you would need less patients in the total trial, at least less patients on the active drug, so that would reduce costs, I assume. But do you feel would it be necessary to first demonstrate the validity of the biomarker in a regular stratified trial before then being able to move on to an enriched trial design?
Not necessarily. I think if we look at the sort of criteria I showed today from Drevitz, sort of on causality and drugability, targetability, and so forth. So if there is if you have a marker which shows a causality that can come from an observational study, or it could also be compounded by animal studies or cell type studies, I think there is probably enough evidence to do that. The causality point in psychiatry is a difficult one because there's never ever a single cause. There's always a mix of biological and environmental factors. And that makes it a little bit more difficult, I think. But therefore, I think if you have different factors, environmentally and biological, and you put them perhaps together in a model, that might also be a way of enriching then a patient group. But I don't think that we need to show clear causality first, treating that pathway, and only then can move to a trial like that. But networking trials, I think, is another important part. Most of these trials published, including our own, have been done in one center, perhaps two centers. But I think we need a larger network with different centers of doing these trials to get numbers.
Yeah, indeed. I'm going to go to Janet and then Igor and Carmine.
I agree with a lot that's been said already. I would like to introduce an idea that instead of focusing on one biomarker, that we try and zoom in on several, both biomarkers and symptom groups that are, associated with inflammatory subtypes, because cytokines don't work alone, right? They're always working in combination, and depending on the combination, they're steering in different directions. So I don't think one biomarker is going to do it for us. We need combinations, and we don't know what the combinations are. So I think framing a group that, the 20% that we do believe immune system is activated, and then from there on stratifying biologically across like several biomarkers and symptoms, and other factors to try and further our knowledge as to really what the group is that will be likely to respond. And I think we should be resisting the temptation to try and extrapolate it backwards to the entire depressive diagnostic group, because I don't think that's ever going to work.
Okay. Igor.
Yes, I would like to stress further the idea of this permissive causality. I really believe that this is the type of causality that links immune dysregulation with psychiatric disorders. So there is no direct event outcome relationship between the two, and in this case, the context is really key. So I think that stratification for different immune profiles is very important. However, can be even more important to stratify for environmental and biological factors, because this can really group together patients to produce a specific outcome. So I really believe that we cannot also, according also to what Bernhard said and Janet said, we should consider not only stratification for immune alterations, but for contextual factors.
Yes, thank you very much. And there was also a comment in the chat by Hemo that childhood trauma was missing from the definition of patients, and I do agree with that. I'm going to go to Carmine and then Hemo.
I wonder whether I can be kind of bring it back to the evidence we have so far, and think about, rather than throwing away the whole idea of stratification based on a biomarker, in fact, even about stratification on CRP, while we try to reflect a little bit more of why some study, even the few studies that have done the stratification, some have failed and some have not. And no, I mean, it is possible. Our study was quite small. It is possible that, we are false positive, and that actually dividing CRP by above or below 3, it's not a real effect. But I mean, it is there. And of course, and the Miller study with TNF-alpha as antagonist showed a clear effect. Bernhard has shown that it's not in relevant predictors with causality. So is it possible that actually, I mean, maybe just by luck, we've identified that CRP identifies a group of people that respond to some anti-inflammatory, not others. So in reality, so that these are real differences between the trial. They're not just kind of random noise. There's something about minocycline and perhaps the TNF-alpha antagonist that the celecoxib is unable to do. I mean, whether it's due to penetration in the brain, ability to regulate microglia or not, ability to influence kynurenine or not, ability to work on one or another of cytokines mechanism. And obviously we know that COX is a very specific effect. Minocycline tends to be much broader. TNF-alpha, arguably the TNF-alpha antagonist also is very broad. In fact, if you look at Andy Miller's data from the original trial, IL-6 goes down dramatically with the TNF-alpha antagonist. So maybe either we can use the CRP as a stratification, but we need to have an anti-inflammatory that's a really broad action, or maybe we need to think about, okay, what is the key clinical, what is the key biological effect that worked? I know by chance we were lucky with minocycline, it didn't work with celecoxib. I wonder whether some of this work can be done, and maybe the next trial can just be a stratification with and then going with a treatment that we know why should work with that stratification.
So it should be both the right biomarker and the right treatment.
Yeah.
Basically, you're suggesting that with the evidence that we already have now, we could go for an enriched trial, including only patients with a CRP over 3, and then comparing head-to-head minocycline, celecoxib, TNF-alpha, placebo, and really looking at which treatments work for that specific group of patients.
Or even just a standard kind of, stratification of above and below 3, but then just go for do a really large trial with a medication that tap in the same mechanism of minocycline and the TNF-alpha antagonist, which I wouldn't know which one it could be, but it could be a new medication or a purpose medication. We should use it, I think, to understand more about the mechanism of the therapeutic action. And it has to do with something with the brain, right? Because CRP doesn't change. Okay, or maybe CRP, as you said, is not good in showing changes, it's only good to kind of stratify. Sorry, more questions than answers.
So much questions, yeah. A comment by Hemel.
Yes, well, I want to follow up actually what Janet says, but go much further. First of all, do we all believe that real depression exists, and schizophrenia, and bipolar disorder? Perhaps the latter, yes. Is it not imminent now to just make immune diagnosis and say then, okay, this gives us a certain set of symptoms which are probably not overlapping with your depression or schizophrenia. Symptoms also including autoimmune phenomena. So symptoms also including infection rate, because there is this, what you call comorbidity, and redefine in a sort of Virchow's way in 1848, on the basis of laboratory data, the diseases. We tried to do that in mood stratification. Now we see I can subdivide depression into 4 endotypes. And a major criterion there is mitochondrial dysfunction in monocytes and probably in other cells as well. In bipolar disorder, this is not the case. There it's a small T cell defect, particularly the output of naive T cells from the thymus. And in fact, what we are doing is making internal diagnoses, internal immunological diagnoses. And now we have to find the treatments for that and treat till our parameter goes down. Our T cells should improve. Our mitochondrial dysfunction should improve. And in the slipstream of that, in some of the cases, inflammation will go up. But we have to turn it around. Forget about your psychiatric diagnosis. Don't try to find biomarkers for them. Biomarkers is, I don't like the term, because it's the actual disease. And so we have to go back and make proper immune or endocrine diagnoses, and then treat these with drugs, which are sometimes available, sometimes they are not, and then see what kind of symptoms are improving in the same time. It could simply be the feelings of sadness, but not the vegetative symptoms in depression, for instance, or signs of psychosis, and leave others intact. But I think that is the way to go forward, really, in the end. So you probably need cellular functions as well. I know it's very difficult for psychiatrists to think about taking blood and doing all sort of lymphocyte facts analyses and what have you, but hematologists do it every day for the diagnosis for leukemia and to stratify patients for cytotoxic.
Nei, sånn offisiell sånn rating, det 3 timer på torsdag og 3 timer på søndag, men
so you need to switch off your microphone.
Okay, I think this was my pledge,
yes,
to go much further than looking for biomarkers.
Okay, that's clearly understood. We have only 6 more minutes, so I'm going to allow one more comment by Ludger and then the closing remark by Brenda.
Ja,
Oh, thanks. Just maybe check. I think I'll wait forward. Can you hear me?
We have a problem understanding you, or at least I do.
Yeah.
Okay.
Well, I think there is somebody who's not muted. Toru is not muted, and I think that's giving the signal. Rick, is it possible for you to mute people? Can you mute Toru?
He's not muted. Can you understand me now? No.
It's muted. Okay. But we still have the problem, Ludger.
Well, then I've written it in the chat. Look at the chat.
Okay. I'll open the chat and read your comments. So Ludger thinks the way forward for clinical immunopsychiatry is to broaden and standardize the clinical diagnostic instruments, which we already have, like MRI, EEG, CSF, and PET. There are very strong signals in many single cases which can guide our therapy. And these are really strong signals, but unspecific, and we should focus on this and combine it with other biomarkers. And I do know you've explained previously, Ludger, that at least in your hospital, first episode or treatment-resistant patients with depression, with psychosis, are routinely examined using this wide range of technical investigations. I don't think this is the case everywhere yet, but it certainly is paving the way forward.
Very important. Can you understand me now? No. Okay.
With difficulty.
Yeah, maybe this afternoon.
Okay. Thank you. And then Brenda, I'm going to leave you to make the final comments and closing.
I think we do have a few minutes, and I know that there is somebody who also raised his hand.
Yeah, and we have the
quite
comment
a
in the
few
chat.
times.
Yeah.
But I don't see a camera on. So Anupam Sa, maybe
Hi,
you can put
thank
your
you.
on your camera if possible.
I have
ask.
some problems. I have some problems with my camera, but I can ask the question. So my question is that since anxiety is frequently associated with depression, with all the studies shown today, did anybody investigate the effect of inflammation on anxiety and subsequently the treatment response?
I think the silence is telling you that probably nobody directly looked at that, at least not focused on an anxiety population. Bernhard, you raising your hand?
We haven't done that, but there's a review come out last year looking at anxiety in young people, so adolescents and early adults, and they couldn't, again, small studies, but there was no effect on anxiety in particular. But it also has to do with the fact that anxiety and inflammation is not a strong link or immune changes as it is in MDD. So,
yeah.
Okay, thank you.
And also some people in the chat are commenting about studies looking into that.
Yeah, Brenda was an opponent for one of my PhD students, and we looked at leptin and the adipokines in neuroticism and anxiety, and actually did see an effect that was independent from the depression. And it was a little bit bigger, actually, than the effect we saw in the depressive patients. So I do think there are some mechanisms that we're going to be seeing more of in anxiety rather than depression. But they might be a little bit different in appearance than what we're seeing in the severely depressed.
Yeah, but I think the question was also regarding intervention studies. And I think right now there are not that many intervention studies that are zooming in on inflammation and anxiety, maybe as a secondary outcome in some of the depression studies. But I think that's all the evidence we have right now. So.
Although it was an endpoint in the studies looking at patients with known autoimmune disorders and the effects on both anxiety and depressive symptoms, where they do have an outcome for both depressive and anxiety symptoms with effects. So from the other direction, they have some data.
Great. Well, I think it's actually 2 minutes before noon, and we are supposed to have a lunch break now. In the afternoon, I know that there is a junior session and a senior session. There are 2 separate Zoom links. In the junior session, which starts at 1, it will be the talks will be about professional development session for early career researchers, and this will be led by some early career researchers, Marianne Voisel and Noise McGielapui. I'm not sure whether I pronounce it correctly. And they will be sharing that session starting at 1. And there will be a senior PI session also of the members of the ECMP Immunoneuropsychiatry network. And I think probably in both groups there will be discussion on what are next steps, because I think this morning session showed that we do know quite a lot, and I think there's no doubt about the link between the immune system and psychiatry. However, I think the more we hear about it, the more questions arise also. And I think several of these questions were discussed this morning. And I think it also shows that this is not a very easy field, that there are lots of complexities, like in everything we do in psychiatry, and that truly exists in this field of immunopsychiatry as well. However, I think the good news is that some of these complexities we can actually study, we can do more research on. And I think we heard excellent talks. I really would think that it would be great if some of the discussion points and some of the action items we may actually think about writing down in a nice paper. I think one of the challenges of our field is that I think we probably here all in this call are believers. We believe that this is a very important area of research and clinical work. However, I think there are also some disbelievers. And I think that also comes because there are some negative studies published. And as we all know, that there are probably reasons for some of these negative findings, and actually challenging situations and raising questions on why these negative findings are there. I think these negative findings also sometimes raise criticism about, is this a relevant field? Are we really ever gonna see and select patients and target immune dysregulation to improve mental health? I think these are challenging questions that we need to deal with. And I think being clear about the fact that it's not so easy, and that there are obviously lots of remaining questions that we need to address in order to move the field, and especially the clinical implementation of the work we're doing, I think are really necessary steps. So I think that this is really something to further discuss the afternoon, how to contribute to that, what can we do as a network, what can we do in future studies together. I think a lot of topics that were discussed are involving further collaboration, further sharing of resources we have, sharing of mechanistic approaches we can do. So I think those are really important steps to take as a network. And I think this morning really repeated that is what we need to do. And for that, I think it's really appropriate to have a network, and with so many attendants listening and raising questions to the presenters. So I would really like to thank everybody who participated, all the presenters and all the attendees, and for you of raising questions. And I think it was a very interesting and exciting morning. Thank you very much, and we will continue to be in contact with you.
Thank you, Brenda.
Thank you very much, Brenda.